Wenckebach periodicity has classically been considered an AV nodal phenomena and is essentially considered benign unless associated with higher grades of AV block. Wenckebach at the intra or infrahesin level has been scarcely reported in literature. The distinction, however, becomes critical as infrahesin Wenckebach is a harbinger of complete heart block and hence necessitates permanent pacing, contrary to AV nodal Wenckebach. Identification on the 12 lead is therefore imperative as accurate identification of an infrahesin Wenckebach can be valuable in formulating the further plan. We therefore aim to study the clinical and electrophysiological profile of such patients. We started this study was conceptualized in the beginning of the conduction system pacing era, but materialized in Jan 2021 as conduction system pacing had become the default strategy in our center, and a diagnostic quadripolar EP catheter would be kept at the His bundle in almost all cases of permanent pacemaker implant, which allowed us to uncover more cases of infrahesin Wenckebach which previously would have been missed. We prospectively started collecting patients from that period. Over the last 1.5 years, we have recruited 93 patients. In the initial 6 months, the recruitment was poor, which was marred by the COVID pandemic. The study is ongoing. I am presenting here the data collected till July 2022. The study aims to recruit patients till the end of this year. So we included patients with a clinical all patients with a clinical diagnosis of AV block, including high-grade AV block, who were candidates of permanent pacemaker implantation according to standard clinical indications. Also included were candidates of cardiac resynchronization therapy with or without defibrillator. Informed consent was taken from all. Excluded were patients who had a tachyarrhythmia indication for a EP study where the conduction block was presumed catheter-induced or iatrogenic. Obviously, sinus node dysfunction indication of a pacemaker was also excluded. An EP study was done in all of the patients using the right femoral venous axis. A quadripolar diagnostic catheter was placed at the His bundle area and another at the high right atrium. If 1:1 AV conduction or a Wenckebach periodicity was noted spontaneously at the beginning of the EP study on table, incremental atrial pacing was performed beginning 20 milliseconds slower than the sinus cycle length and was continued till 500 milliseconds or 2:1 AV block, whichever was earlier. PR interval, QRS duration, AH and HV intervals were measured. Now, patients who had an atrial fibrillation with underlying complete heart block or planned for an AV nodal ablation followed by pacing as a part of ablate and pace strategy were converted on table before the EP study with ebutilide with or without DC cardioversion. Now, coming to the results, as I just mentioned, over the last 1.5 years, we have recruited 93 consecutive patients of AV block. The recruitment is poor in the first 6 to 7 months, which was marked by the COVID pandemic. And interestingly, the incidence of infrahesin Wenckebach was quite high, 11.8%, 11 out of 93 patients, which was higher than expected. 8 patients were also found to have nodal Wenckebach. 1 patient was found to have both evidence of an nodal and infrahesin Wenckebach. This table jots down the clinical and EP characteristics of all the 11 patients. We can see the characteristics studied were in the age, gender, history of an ischemic heart disease, underlying ejection fraction, the clinical presentation, the underlying conduction system disease, ECG characteristics, the Wenckebach cycle length, and EP characteristics as described. And then we compared these characteristics with the corresponding characteristics of nodal Wenckebach patients. We can see here that almost all patients had syncope as the presenting symptom, with a bifascicular or trifascicular block which was present in most with a minimal PR increment. You can see there is a column which is written delta HV21. That is the difference in the HV interval in the second beat of the Wenckebach train compared to the first. There was a minimal HV increment in the second beat of the Wenckebach train, except for case 2 where there was an isolated high value of 103 milliseconds. All these patients had a baseline evidence of a infrahesin disease as evidenced by the prolonged HV interval. You can see the baseline HV interval is more than 70 in all of the patients. However, 4 patients had a QRS duration, as you can see. 4 patients, case number 3, case number 4, case number 6, and case number 8. 4 patients had QRS duration less than equal to 120 milliseconds. And one of them, case 4, had no evidence of a conduction system disease except for an isolated prolonged PR. Hence, a narrow QRS with no bundle branch block at baseline if presence with a Wenckebach periodicity may still not be nodal and hence not benign, contrary to the classical teaching. We compared the characteristics of both infrahygiene in nodal Wenckebach patients and found that patients with an infrahygiene Wenckebach had more affliction of the female gender, had more affliction of the female gender, were more likely to have an underlying cardiomyopathy or ischemic heart disease with wider QRS at baseline, with most of them having a bifascicular or trifascicular block and with a normal PR interval compared to patients with nodal Wenckebach. The most important thing was a minimal PR increment. You can see as in the last row, minimal PR increment in the second beat of the Wenckebach train compared to patients with nodal Wenckebach. Hence, to summarize, infrahygiene Wenckebach in our group study population had more often associated bifascicular, trifascicular block and less likely to have an isolated first degree heart block. Baseline PR and PR increment, minimal PR increment in the second beat of the Wenckebach train was significantly less in infrahygiene Wenckebach, and the Wenckebach train length was shorter in patients with an infrahygiene pathology. Now coming to some of the case examples, I'll take the case 2, which was published in Journal of Cardiovascular Electrophysiology, the case where we had the highest PR increment. On the baseline ECG, you can see the ectopic atrial rhythm with intermittent. With intermittent.
Basically, Brugada is a
with
rare, but it.
Some of the audio is coming. Can you block that?
With intermittent inverted P waves, what we found on the EP study was a Hessian automatic escape rhythm. A Hessian automatic escape rhythm with an infrahygiene Wenckebach and intermittent HA dissociation of suprahygiene AV block. One of the other cases, case 3, who had a bifascicular block, and you can see the patient had a 4:3 and 3:2 block at baseline. We saw in the EP study, as marked by the annotations, there was a minimal HV increment in the second beat of the Wenckebach train, followed by gradual prolongation and ultimately a block. This is another case where we had a narrow QRS and no evidence of a bundle branch block at baseline. Only thing on the EP study, patient had a baseline prolonged HV interval. As you can see from the bottom left slide, the patient had on atrial pacing, on incremental atrial pacing, and infrahygiene Wenckebach with minimal PR increment on the second beat of the Wenckebach train and a constant AH interval. This is a prototype patient with a trifascicular block, and again you can see on the EP study a fixed AH and infrahygiene Wenckebach with minimal HV increment in the second beat of the Wenckebach train. This is another patient with a 2:1 AV block with LBBB. Again, had evidence on the left lower corner of the screen and evidence of infrahygiene Wenckebach. So a QRS duration of 130 milliseconds based on the Uden index with trifascicular block had a high sensitivity and specificity to predict infrahygiene Wenckebach based on the surface ECG. A baseline normal PR and a minimal PR increment in the second beat of the Wenckebach train were more likely to be secondary to infrahygiene pathology. On review of the literature, we could find only 8 case reports with a total of 11 patients, which is equal to our study population. Analysis of that found an incomplete analysis, but again their finding was that those patients had a bifascicular or trifascicular block as the predominant presentation. Now coming to the conclusion, this is the largest series of infrahygiene Wenckebach patients and the first study to actually describe the clinical and EP characteristics of such patients till date. It's not so rare in the era of conduction system pacing, where EP study is more routinely performed, and most importantly, infrahygiene Wenckebach comes with a characteristic ECG signature, which may help in differentiating from nodal Wenckebach patients, which is otherwise considered benign. Thank you, sir.